Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum assalam.
Thank you so much for inviting me to this great conference. As a surgeon, I have to say I'm really glad to be in a cardiology conference, but I have one disclosure to make. When I saw the name of Dr. Tariq Hilmi on the list, I was excited to see Dr. Tariq Hilmi, one of the greatest coronary surgeons in the Middle East. But it turned out to be a very exciting session by another Dr. Tariq Hilmi. It was really, really good talk, and really a great session by my other esteemed colleagues here. Without further ado, today I'm going to speak about how we deal with diffuse coronary disease surgically, and is endarterectomy a good option? Coronary artery disease has a very classic pattern. When it develops, it tends to develop proximally. It tends to develop proximally and at bifurcation sites due to hemodynamic and shear stress forces. Atherosclerotic lesions tend to develop at these sites proximally. Luckily, we're able to help the vast majority of these patients with coronary bypass surgery. We bypass the first third of the vessel, and we achieve relief of ischemia, improved LV function, infarct prevention, and longevity. But bypass principle is usually you need to have a good inflow and a good target to achieve the best result. Unfortunately, that's not always the case. And if you tell me to name one reason why this is not always the case, it's because of diabetes, really. In the syntax study, which was one of the largest study that actually examined CABG versus PCI, the percentage of diabetic patients was 25% in both groups. Is it the same in this part of the world? Definitely not. In our center, patients undergoing CABG, 77% of them are diabetic. So we deal with their very different pathology than the pathology we face, than the pathology in the Western world, basically. So this is one of the recent patients. We had 39-year-old patient with poorly controlled diabetes, and these are the vessels we deal with. So basically, what's a bad target? There is no real definition for that, but Doinst and colleagues actually summarized factors that affect graft patency in coronary bypass surgery. The distal vessel, there are patient factors and surgical factors. Distal vessel runoff, the size of the target vessel, the quality of the target vessel, degree of competitive flow, presence of distal atherosclerotic disease. Surgical factors include things like the quality of the graft material. Sometimes we get a good lima, other times we get really small lima that's fibrosed. Also with the veins, if you harvest a vein properly without adventitial injury in a no-touch technique versus if you harvest a poor vein, this will definitely impact your graft patency rate. The graft type, arterial versus venous grafts, the quality of the graft, the proper alignment and geometry of the graft, and the quality of medical therapy post-op. All of these factors play a significant role in graft patency long-term. So when we face a poor target, we as surgeons, we have a mental checklist, if you will, that we go through when we look at an angiogram. Why are we doing bypass on this patient? Is there a flow-limiting lesion? Is there inducible ischemia? And what vessels are we going to bypass? Can I have a pointer? This is a pointer. That's a pointer. So yeah, what vessels are we going to bypass? Are we going to bypass something like this here? This distal circ, low OM? Or are we just going to bypass by territory, just one graft in each territory? Or should we bypass every vessel we see? Where to put the graft? If you sort of open here on the artery, you may run into a plaque, that will be problematic to sew, and how you deal with problems if you open on a plaque, if you open on a bad vessels. So all of these questions we ask ourselves, why we do this, why and how we're going to deal with this. Opening on a disease segment is a quite frequent thing we see actually nowadays. Classic angiogram, the classic angiogram really is not a reflection of what we see intra-op. So option one, if we have a diseased vessel and we happen to open on that vessel and we're able to pass a 1.5 millimeter probe distally, we just sew there. That's my approach. We just sew the target, sew the conduit on the target using meticulous technique. The use of the Everpoint needle has been a great advancement in coronary surgery for the last 10-15 years. It's a tungsten rhenium needle with multi-layer silicone coating. It is designed as a sharp and bend-resistant needle with superior flight line penetration through the first pass compared with stainless steel needles. So they're substantially more expensive than stainless steel needles, but they're used in bad targets like the ones we showed you. Another option when you open on a diseased vessel is to extend the arteriotomy longer into a healthier segment and just sew a long anastomosis. The third option is to perform a coronary endarterectomy, which is removal of the plaque. A coronary endarterectomy basically can either be planned or unplanned. Planned when you see a vessel on the angiogram, multiple skip lesions, diffuse disease, you say tomorrow I'm performing an endarterectomy in this patient. Unplanned is when you open the vessel, you're surprised when you sew, there is plaque disruption that you cannot reliably sew your conduit to, or the lumen is too small or absent. That's when you do it unplanned. Coronary endarterectomy is an old procedure. This is an old paper from Denton Cooley in 1986. He reported mortality of 6% in the initial experience, then it decreased to 4%. So basically there are two techniques: open technique in which you open the whole artery and remove the plaque, and a closed technique in which you open a small arteriotomy and with closed traction you actually pull out the plaque. I'm going to be very quick for the time. This is how we do it. Basically, you open a small arteriotomy, and this is a Watson chain. This is a probe, basically. You're trying to probe the artery, and the probe cannot pass. The artery is occluded. This is a Watson chain dissector. You basically elevate the plaque, go around it, and apply gentle traction. First proximally, and I have less than 1 minute, I have to go fast. Basically, technical pitfalls. Number one is incomplete plaque removal. Number two is shearing off of the side branches, the diagonals and the septals, and adventitial disruption. This is what it looks like post-op. The snow plow effect is something that I really like to talk about in this technique. If you ever saw a snow plower, the snow plower actually clears the street in the middle, but actually blocks the sideways and the driveways on the side. That's what happens if you don't do it carefully. Like you see the segment on the left side is an ugly segment of an endarterectomy where the side branches are sheared off, exactly like a snow plower clears the middle path and blocks off the sideways. So this is a technical pitfall in endarterectomy that we have to avoid. This is the largest experience. I'm going to go quickly to the last slide. What happens? I will show one slide of what happens 1 year post endarterectomy, if you allow me.
Okay, this is the last slide, please.
So this is a Japanese group that reported their outcomes. Panel A is the pre-op image of the vessel. Panel B is the immediate post-op angiogram. You see the vessel is lacking endothelium. It's a bit boggy. And this is what happens 1 year post-op. You see nice septals coming off the LAD with a patent graft. The graft really calibrated and it matches the size of the LAD. This is coherent tomography, 1 year post-op. On the left side, it's immediate post-op. You see the vessel lacking the intima. And what happens post-op 1 year after is basically the vessel is completely endothelialized. So in summary, it's an excellent technique if done properly. It carries slightly higher mortality. Paying attention to technical pitfalls is really important in this technique. And thank you so much.
Thank you. Thanks very much, Dr. Haitham.